As we recall in the last section, HIV has affinity for CD4 expressing T cells and myeloid cells, which is the major determinant in disease pathogenesis. HIV-induced immunodeficiency, AIDS, results from the great reduction of CD4 T cells. How does the virus destroy the target cells? There are direct and indirect mechanisms. HIV can destroy the target cells as a result of budding. Continuous formation of viruses budding from the infected cell surface causes cell damage, increased permeability, and finally cell lysis. CD4 T cells can be infected with the cell-borne HIV or by cell-to-cell transmission of virus upon binding to the dendritic cells. The HIV infection causes syncytial formation and interferes with cell metabolism, leading to the cell lysis. Furthermore, large amounts of non-encrypted circular DNA induce infected T cells to commit a type of inflammatory cell suicide, pyroptosis. Pyroptosis may lure more unactivated T cells to the site and also succumb to pyroptosis. At the same time, the immune response to HIV controls viral infection but also contributes to pathogenesis. Cytotoxic T cells, natural killer cells, can induce immune cytolysis, resulting in the killing of CD4 T cells. On the whole, HIV infection alters the function of T cells, dendritic cells, and macrophages. Virus reduces CD4 T cell numbers, helper cell activation of CD8 T cells and macrophages. On the other hand, HIV takes advantage of several ways to escape the immune control. We can see in the table, GP120 undergoes mutation and heavy glycosylation, and hence alters its antigenicity and invade immune clearance. Direct cell-to-cell spread and syncytial formation also contribute to escape of antibody detection. Moreover, persistent infection of dendritic cells, macrophages, and CD4 T helper cells may lead to loss of activators and controllers of the immune system. Ultimately, the entire immune system is compromised. If this progresses, the final result will be immunodeficiency. The course of HIV disease parallels the reduction in CD4 T cell numbers and the amount of virus in the blood. There is a large burst of virus production and viral replication in the lymph nodes, causing disruption of structure and function. CD4 T cell numbers drops greatly in the late course of the disease. Finally, the patient becomes immunodeficient. Loss of CD4 T cells affects both cellular and humoral immune responses. The patients are susceptible to opportunistic diseases and malignancy. In addition, HIV-infected macroglial cells destroy neural function, causing neurological abnormalities. The flow diagram depicts the pathogenesis of HIV. We can see HIV causes latent and latent infection of macrophages, dendritic cells, and CD4 T cells, and affects neuron functions. The consequences are immunodeficiency and AIDS-related dementia. As you all know, HIV is the causative agent of acquired immune deficiency syndrome, AIDS. AIDS is one of the most devastating epidemics ever recorded. Without treatment, most HIV-infected individuals will become symptomatic and ultimately succumb to the disease. What's the cause of HIV infection? A typical course of HIV disease undergoes 3 stages, from an asymptomatic disease to immunodeficiency. The first stage is acute infection, followed by clinical latency. Many individuals experience flu-like symptoms, occurring approximately 2 to 4 weeks after exposure. During this acute phase, HIV infection is spreading and the viral load in the blood and other body fluids can be quite high, increasing the risk of transmission to others. p24 antigen and viral RNA can be detected, while anti-HIV antibodies are not detectable in this period. During the asymptomatic period, the viral replication continues, leading to gradual decline of CD4 T cells. Viral load can be also measured, which plays a major role in evaluation of the patient's status and prognosis. HIV antibodies can appear in this phase. The second stage is subclinical immune dysfunctions with CD4 T cell counts continuing to fall. The individuals may present with acquired immune deficiency syndrome related complex symptoms such as fever, weight loss, GI problems, and muscle pains, and generalized enlargement of lymph nodes. As the immune system collapses, opportunistic infections develop. Without treatment, what is the final fate of infected individual? In the third stage, most HIV patients eventually progress to full-blown AIDS when CD4 T cell counts are less than 200 per ml and viral load is larger than 75,000 copies per milliliter. At this time, they show significant diseases, including generalized enlargement of lymph nodes, fever, opportunistic infections, cancers, HIV wasting syndrome, and AIDS-related dementia. AIDS patients are susceptible to opportunistic infection and stable. We may see the common infectious disease caused by various agents in AIDS. The relevant agents including Candida albicans or other fungi, viruses capable of reactivation, parasites, and tuberculosis bacillus or other bacteria can result in significant infections. The pictures here show the lung with pneumocystic carinal infection in an AIDS patient. Pneumocystis carinal pneumonia is one of the major complications of AIDS. As you can see, Candida infections is another overt manifestation of AIDS. Oral candidiasis thrush, causing the appearance of sores in the mouth, and systemic candidiasis are common problems for AIDS patients. Prolonged and severe viral infections, including reactivation of the herpes viruses, also often occur. The immunodeficiency may involve the onset of the malignancy. As the table shows, the most notable is Kaposi sarcoma. Lymphomas are also prevalent. What can you find in these two pictures? There are the lesions of Kaposi sarcoma on the skin. The cancer is associated with a herpes virus infection. type 8, which is rare in healthy people. Lymphomas are also prevalent in AIDS patients, such as Hodgkin and non-Hodgkin lymphomas. At the same time, the AIDS patients will develop AIDS wasting syndrome, characterized by enlargement of lymph nodes, fever, weight loss, malaise, opportunistic infection, diarrhea, night sweat, and fatigue. Furthermore, some AIDS patients exhibit manifestations of AIDS dementia complex, including HIV, encephalopathy, and AIDS-related dementia. Overall, late stage generally are burdened with tuberculosis, pneumonia, severe diarrhea, whereas malignancies or AIDS-related dementia without treatment, a patient who succumb in 9 to 11 years. Till now, we have finished this section. Next part, we will discuss about the epidemiology and lab diagnosis of HIV.